Hello, everybody. Welcome everyone here and later on YouTube. Let me introduce my PhD thesis, Fertility-sparing treatments in gynecological cancers. And I found this. So, my name is Ádám Vincze. I'm a resident doctor in the Department of Obstetrics and Gynecology. My supervisors and I share a vision that women can keep the ability to reproduce even after their appropriate oncological treatment. We would like to achieve that through finding the best fertility-sparing options for these women. We have two specific goals in mind. The first one is about cervical cancer, and the second one about endometrial cancer. So our first project is titled Investigating the Efficacy and Safety of Fertility-sparing Treatment in Early-Stage Cervical Cancer equal or above 2 centimeters. A bit of background. Cervical cancer is the third major cause of oncological death in women. 40% of it is diagnosed in an age frame where fertility preservation is key. Fertility-sparing surgeries like conization, trachelectomies are oncologically valid alternatives to radical hysterectomy in those early stages where the tumor size is below 2 centimeters. Excellent recurrence rate is below 4%. However, where the tumor size is above the 2 centimeters, it becomes too large for the upfront surgical approach, and the pregnancy rate drops dramatically. The idea is that with the help of the neoadjuvant chemotherapy, we could shrink the tumor and potentially downstage the disease for a less radical surgery. Our aim to find an oncologically safe, fertility-wise sufficient approach for these women. The clinical question and PICO framework reflects that. We would like to find the best one for these women with the larger tumor sizes. The intervention is neoadjuvant chemotherapy followed by fertility-sparing surgery, and the comparator is upfront surgery. We're investigating oncological and fertility outcomes. In our hypothesis, the neoadjuvant chemotherapy followed by surgery provides less recurrence, more pregnancy. With this, we could take another step in order to expand the inclusion criteria of fertility-sparing approach. On this slide, you can see our search key. It consists of 2 domains. The first domain is about the disease, and the second one about the intervention. We found around 12,000 hits among 3 databases. And after the duplicate removal and the title and abstract selection based on title and abstract, we got around 300 articles. And currently, with my selection pair, David Murray and his newborn, working on the full text selection. So we're currently at this stage. And because we're getting hungry, let's jump to the next slide. So this slide shows a preliminary forest plot. The pregnancy rates for the upfront surgery and the neoadjuvant chemotherapy followed by surgery groups. Pregnancy rate is a great tool to assess the treatment's impact on future fertility. It's a proportion. For example, if the pregnancy rate is 0.28, that means that out of 100 treated women, 28 could become pregnant. So the analyzed cohorts contain 300 and 200 patients from 6 and 11 studies. Keep in mind that these studies are observational ones. The heterogeneity is I-squared 0% and 15%, but the confidence interval are fairly wide. The pooled pregnancy rate for upfront surgery was 0.06, in contrast to the others 0.28. The subgroup analysis revealed statistically and clinically significant difference in pregnancy rates between these groups, suggesting that the neoadjuvant chemotherapy containing group may result in better pregnancy rates. Again, I want to highlight that these are observation studies. Let's jump to the second topic. It's about endometrial cancer, investigating the efficacy and safety of the fertility-sparing treatments in atypical hyperplasia and endometrial cancer. Endometrial cancer is the 4th most commonly diagnosed cancer with a rising incidence rate. 4% of it is diagnosed earlier than 40 years old. Again, fertility preservation is key in this age group. atypical hyperplasia is a premalignant condition, typically treated with in a similar manner like early endometrial cancer. The fertility-sparing approach should start with a hysteroscopic resection, but after that the treatments can vary. It should contain progestins either orally or intrauterine device delivered, and metformin could be part of the treatment as well. Our aim to find the best fertility-sparing treatments for these women. A clinical question, PICO framework, again reflects that. We would like to find the best treatment for these women who undergone hysteroscopic resection, because according to the guidelines, it should be the first step. The interventions are progestins, either oral or hormonal IUDs, and metformin, and their combinations. We're investigating, again, oncological and fertility outcomes. In our hypothesis, the combination of the three of them provides the best results, and the clinical and research implication that we want to highlight the differences among these treatments and have the clinical decision making. The preliminary research was conducted with this search key. It consists of two domains. First one is about the diseases, and second one about the treatments. And there are previous systematic meta-analyses in this topic, but they do not contain metformin as treatment option, and new articles came out since their searches were done. In summary, we got two articles, I mean, hopefully. So the one about cervical cancer, we're planning to submit since until next September, and about the endometrial cancer until 2026. I don't know how could I be this quick, but I would like to finish with a quote from Marcus Aurelius: "Is the truth I'm after, and the truth never harmed anyone. What harms us is to persist in self-deceit and ignorance." Thank you for your attention.
Thank you, Ádám. And I would like to ask the first question. How could you alleviate the well-known mutations, for example, the poly mutation, your results?
Excellent question. So good question. So you can go on a fertility-sparing approach if we have a tissue sample, and we know that for example, for the first topic, it's squamous adenocarcinoma. You're talking about the second topic, sorry?
Yes, of course.
Yeah, the second topic. It's a great question. I can't answer for that, sadly. Maybe next project.
May I recommend to extend the examination for this? Thank you.
Brilliant presentation and progress, and thank you for mentioning the baby's key role in the selection.
Oh yeah.
So my question is, in the first project, do you know that if there are different types of neoadjuvant chemotherapy protocols, if there are, do you plan to do subgroup analysis of them?
Thank you for the question. Yeah, so there are different chemotherapy regimens. The most frequently used is TIP or TP without the ifosfamide. It's paclitaxel and cisplatin, but nowadays they tend to change the cisplatin to carboplatin, and there are different, like usually every third week they get the treatment, but there are like those dense regimens where they get it every week. So we are planning to do that if we have enough data. Yeah, thank you.
Great, thank you.
Excellent presentation. My question is also regarding the chemotherapies. Do the different chemotherapy protocols have known effects on fertility? And
thank you. Yes, so ifosfamide got taken out because it is known gonadotoxic effect. So, of course, they have effect on fertility, but the other option is hysterectomy. So, yeah, thank you.
Thank you.